the regional collaborative, so we get to work together quite a bit in that front as well. So today's topic, I was asked to speak about all the chaos that's recently taken place around changes to molecular diagnostics, the way test coverage policy has taken place, how payment policy is applied to those for which coverage is allowed, and some of the real chaos and uncertainty it has led to out there in the genetics community, because things have changed quite remarkably from what had been in place and covered just 2 years ago, before this new system came into place. So Leanne, next slide, please. All right, so with regard to this particular topic, I don't have any conflicts to disclose. Next slide, please. So this is the kind of topic that can render people unconscious if you're not careful. So I'm going to try to be careful, but in order to get you up to the point where you understand the systems in which all these decisions are being made and the sort of policies that have to be followed in order for coverage decision to happen or for pricing to be set in both the clinical lab environment where most of this is, but also on the physician side. I'm going to have to overview some of the basics of billing and coding, then look at the way rate setting is done and coverage policy is done, realizing that we've gone through cycles between where decisions about coverage are made locally versus nationally, and we're right now in a cycle where everything is local coverage decision policy, or LCDs. So I'll go over that, how that whole world works. Then we'll talk about the recent changes that took place in CPT coding of molecular genetic testing and what the implications of that new system are. And then we're going to look at some of the more recent legislation, the Protecting Access to Medicare Act, that has information in it about some requirements for laboratories. This program is really designed to reduce the cost of clinical laboratory medicine in the United States by pretty remarkable levels over the next 5 to 7 years. And we're in really one of the very first phases of that right now. And then we'll talk about some of the next steps that we're doing and others are doing to try to get a handle on some of these problems. Next slide, Leanne. All right, so the basics of billing, coding, and reimbursement. I guess one of the esoteric of sort of the payment side of this thing is you never talk about prices. We talk about the cost of systems because we, as a professional organization, and anybody really, faces antitrust issues when one starts talking about pricing publicly, gets you into this antitrust world. So I'm going to avoid a lot of that and try to stay within sort of the systems themselves. So the first system we think about around billing, coding, and such is the CPT system, or current procedural terminology. This basically tells somebody what you did. The ICD code may be a justification for what you did in a CPT code, but this is really very much about the procedure or the lab test or whatever it is that you may have delivered to a patient. It's administrated through the American Medical Association CPT editorial panel. The Centers for Medicare and Medicaid Services under the Department of Health and Human Services has a seat on that panel, but it is to a large extent controlled through the AMA side. And that whole process of getting new CPT codes goes through evidence collection and submission by those requesting codes, and that becomes the basis by which the new codes are reviewed to decide whether or not they are at the point yet where they ought to be a delivered service. And that's not necessarily coverage policy. That's only policy that says when the AMA panel looked at something, they saw enough evidence to justify them providing a means by which one could bill the service. But there are secondary processes that determine whether or not somebody thinks that's sufficient to have made a coverage decision or not. The next part of the system I already alluded to is ICD, or the International Classification of Diseases. We're in one of the longest transitions of all time to the next version of ICD. We've been in ICD-9 CM probably for 15 years. When I started in genetics, this used to change about every 5 years. And that went through about the early 1990s when we got stuck in ICD-9 land for a very long time. There's about 10,000 or so ICD codes ICD-10 is going to take this to 65,000 and give us much better granularity. But unfortunately, it's been stuck in a lot of politics of organized medicine not being ready to adjust their computer systems to accommodate it. It's just been a very slow process, but it's likely to move over the next year. Now, this is a process overall that is sponsored by the WHO. The U.S. has an independent office down in Atlanta that has been dealing with the U.S. transition between 9 and 10 and other aspects of how the U.S. uses this. Much of the rest of the world has gone to ICD-10 already. Next slide, please. All right, so when a new CPT code comes along, and is approved, it then goes into a process that spins right out of the AMA panel, and that is the first decision is really, is this service that's been proposed to get a new CPT code, is it going to go on the clinical lab fee schedule, or is it going to go on the physician fee schedule? If the decision is made to put it onto the clinical lab fee schedule, then the process by which a price is set for that particular test is done one of two ways. The way that it has most commonly been used, in fact, has only been the way used in genetics up until now, is crosswalking, and that basically means you find another test that's already in the CPT coding system, you look at its price, and if it is technically very similar to the test that you're now trying to get priced, they just crosswalk that price over to this new test, and that's assigned by CMS. And is subject to all, there's lots of reductions. Congress periodically says we're only going to pay 20% of what CMS sets the price at, or 70%, or whatever it might be. So there are political overlays on the pricing that can impact what you actually get paid in the end. But ultimately, CMS is responsible for the crosswalk process. However, there's also a system in place that allows for a brand new test, something or service that's never been seen before, and for which there is nothing to crosswalk, to go through a process to set pricing, and that's called gap fill. And we'll talk more about gap fill, but basically what it means is that over a period of months, when the new CPT code goes into the system, laboratories, in this context of molecular diagnostics, we're talking about laboratories, they would actually submit a bill. They would then react to what they get paid or not paid if it's not decided that it's not covered, and they would begin a negotiation with the payer, being Medicaid or the Medicare advisory, or excuse me, Medicare administrative contractors. These are the entities that are out in each of the regions of the country. There used to be, not just a year ago, there were 20 of them, and they're consolidating down to about 10 right now. But one interacts with these Medicare advisory or administrative contractors to negotiate your price. You tell them, you know, that cost me way more to do that test than you're actually paying me, and presumably over time, all of the MACs around the country are doing the same thing, and they come to sort of a negotiated price for what's appropriate for the test that's going through the gap fill process. Next slide, please. So this is sort of the big picture. On the next set of slides, we'll talk about that bottom left-hand side that's a little brighter red. But basically, the payer rate setting methodologies there's three different kinds. Medicare has a system, and that's the one we're initially interacting with around these new molecular diagnostic codes that got approved, and realize that Medicare really deals with a fairly unique population, and many, many things that we deal with in genetics in the pediatric population are not really something that Medicare sees much of. But their pricing and whatever decisions they make has an enormous influence on the rest of the system. So we'll come back to the Medicare side in a few minutes. Private payers have a process they walk through. It's a bit variable among the payers. They use the Medicare rates as sort of a benchmark, but then they go through some additional processes where, you know, you can be in the network and have one price, or outside of the payer's network, or where the provider or laboratories outside of the network would have a different price that's set by a percentage of whatever that base price is for people who are in their network. So that's got a whole system of its own, but that's not where we're focusing today. And then Medicaid, that you know, often uses these Medicare rates as a benchmark. On the Medicare side, I've already alluded to gap filling and crosswalking, and we'll go through these other steps in a little more detail. But you can already see, I think, that once Medicare makes a decision about coverage or pricing, it has strong implications for private payers and for Medicaid. And if you don't like what they did, then you've got to start battling over an entire range of different kinds of payer systems. Next slide, please. All right, so as I said, there were two approaches to pricing. If something lands on the clinical lab fee schedule, I just showed you how that happens through crosswalk or gap fill. But when the new CPT codes for molecular diagnostics went in, we actually strongly argued, there was a coalition with the American Medical Association and the College of American Pathologists, Association of Molecular Pathologists, and other laboratory-oriented groups who argued that the professional aspect of interpreting a genetic test or a genomic test was so important to the delivery of the test that it, and actually a fairly expert area of practice, that it deserved to be on the physician's fee schedule and should not have been treated like a standard clinical laboratory test, where many physicians will know what a glucose level means, or they'll know what different kinds of chemical analytes might mean as to normal and abnormal reference ranges. The genetic tests tend not to have that. There is a lot of interpretation, often in very different than most other kinds of lab tests. So if you're on the physician fee schedule, then the process by which price setting is done is really looking at a group of physicians who are involved in similar areas to the new service that's being proposed to have a code. And what they do is say that it typically requires at least 50 experts in the area, and other tests or services are identified that seem to be similar to the one that is being proposed as a new CPT code. And all of those people who are surveyed are asked whether or not they think the work required for the new code is more work than this other service that's already in the system, less, or about the same. And going through that process with a fair number of experts, they arrive at what they think is an appropriate price. And I already commented on the antitrust aspects of this whole kind of activity. Next slide, please. So that was pricing. Now the coverage policy is really a somewhat independent issue. As I said earlier, we're in a time right now where local coverage determination is the process that everybody engages in. It's not a national level coverage policy that applies to all people in the country who get reimbursed through Medicare, but each regional Medicare administrative contractor, of which there's about 10 now, comes to its own decisions independently about coverage. And as we saw with the new molecular diagnostics codes, they came to very different decisions in different regions, and I'll give you some examples of that in a moment. However, it's important to know that coverage policy does have regulatory requirements that are legislated that are associated with it. The LCD process has to specify under what clinical circumstances a test is considered to be reasonable and necessary. The contractor has to develop new or revised LCDs when it identifies an item or service that is never covered under certain circumstances. So for instance, Medicare can't cover screening of pre-asymptomatic individuals. Any screening that's done under Medicare money, things like mammography for instance, are legislated by Congress that allows Medicare to pay for that screening activity. And genetics just led to some serious confusion about what screening was. And then it has to be a public process with public announcements of a proposed coverage policy, access to the Medicare administrative contractor's medical director for questions, and it's a very public kind of process, sadly, much of which was not done in the current molecular diagnostics code development process. Next slide, please. So when something is determined, and this is pretty important for some of the decisions that were made about genetics and genomics in the recent round, when determined that when they make a decision that they're not going to cover a particular service, there are two ways you can say this isn't covered. One is called a statutory exclusion, and this hit us in a really hard way, and unjustifiably so, I think. It basically says that you can't even question the payer. You can't go and make a medical necessity argument. because that's the alternative. They can say it's not covered, but we understand that there may be unique circumstances under which we ought to be paying for something, and the physician can contact us and make their case for paying it in a particular patient's circumstance. And that's fundamentally pre-authorization of the fact that somebody is going to pay for the test. And if you don't go through that, then the patient or someone is left with a post-test negotiation of why didn't you pay that and won't you change your mind? And in those circumstances, it gets pretty ugly because patients often get stuck with the charge when somebody thought that that the test was going to be covered. And that's not uncommon right now because many of the prior things that had been covered have been reversed under the new policy. Next slide, please. All right, so the whole new system of CPT codes is what underlies many of the changes we've seen recently. In 1992, there were really just 5 codes that describe common methodologies that we used in molecular diagnostics. So one, you'd have a code for PCR, or you'd have a code for the probes used, but it was non-disease specific, and understandably was difficult for payers to know exactly what you did, which gene you looked at, which variants you might have targeted in that gene. And despite the fact that they probably didn't know what those variants were anyway, it wasn't entirely clear and transparent as to what that test was. But it worked, and the system just was very difficult to work with because you can only have 5 digits to describe a service in the CPT coding system. And we knew at that time there were 25, actually probably at that time that we thought there were 100,000 genes. We're down to 22,000 or so, but still there wasn't room in the system to be gene specific about the codes that were coming online, and we knew it was going to crash and burn in a short amount of time. So this code stacking was the best solution we had at the time. By 1997, the limitations of that 5-digit coding system were really becoming apparent. We were up to about 1,800 new genetic tests, many of them that might be done for different kinds of clinical indications. So the codes were still methods-based, but the payers were getting increasingly grumpy because the amount of money being put out for molecular diagnostics was rapidly increasing. So the first effort was to overlay a 2-digit alphanumeric modifier that would be attached to the 5-digit code that would describe a gene, but if you can only use 1 through 9 or 0 through 9, the 26 letters, then you're only going to have the capacity for 260 gene descriptions in an alphanumeric system. So that pretty quickly became untenable, and in fact the payers would never buy into it, never adjusted their computer systems to even allow it to have a chance. And that brings us up to about 2010 to 2012, where the payers really were looking for much greater granularity about the tests that were being delivered in genetics and genomics, and were pushing for a new system, and the Association of Molecular Pathologists took a run at developing a much more specific kind of system that could be used in molecular diagnostics. Again, they had to deal with the fact that at that time we were up into the neighborhood of 2,000 to 3,000 genetic tests being delivered in the country. And what they had to do is find sort of a balance between a 2-tiered system, with the first tier being the most commonly delivered high-volume tests. And in fact, the first tier accounts for probably about 80 to 85% of all genetic testing done in the United States. The second tier, which could include just a very large number of relatively rare genetic disease tests, was one that was developed in a complexity basis. So next slide, please. So you get the sense that the Tier 1 is really probably, initially was the first 100 codes that came into the system. Tier 2 was probably a very much larger number of tests, and were very low volume, often very rare disease tests for which we had very limited data on utility, because there weren't systems at that time to aggregate everybody's cases in the country to do analyses of how useful it was to have known the diagnosis for that particular patient. Next slide, please. All right, so to give you a sense of sort of the difference between Tier 1 and Tier 2, here's just some examples of what goes where and what constitutes this complexity-based system. So Tier 1, APC or BRAF testing, BRCA testing, CF for TR for cystic fibrosis, DMD for muscular dystrophies, FMR1 for Fragile X. So these are some very much more high volume kinds of tests that were described in that section, and they could even have more than one code for a particular gene if you knew that you might do sequencing of the gene or you might do targeted mutation analysis, so you could end up with more than one code for one of those genes depending upon what the most common forms of delivery and structure of the test was. Tier 2 is this complexity-based system, and you can see that in level 1, it didn't matter what gene it was. If you only looked at one variant in the gene, then regardless of the gene, it got a code in level 1. Level 2 was 2 to 10 variants were being analyzed in a gene. Level 3, more than 10 variants. So you get the sense of increasing complexity as you move through sequencing, the number of exons in a gene that might be sequenced, all the way out to essentially where we're going nowadays to whole genomes or whole exomes being analyzed. Next slide, please. Needless to say, Tier 2 was not terribly popular. And in fact, many of the payers thought it was just research tests and that they didn't have to pay for them. And they didn't understand that we had to put them in this Tier 2 because there wasn't capacity in the CPT coding system to give them all separate numbers, but that they were valid tests. They were just largely rare disease tests. So in 2011, CMS subcontracted with one of its Medicare administrative contractors. At that time, Palmetto was in the West Coast, what's called Jurisdiction E. They also had several states on the East Coast. And what was unique about them was they had North Carolina, where LabCorp is, and they had California, where Quest is. And that's where the lion's share of molecular diagnostic tests were being done in the country. So having those two got them the contract to look at what they called the MolDX program, or Molecular Diagnostics Program, with the mandate to develop a system for assessing them to make coverage decisions and reimbursement decisions for the 7 states that were under them. By 2012, the first wave of those first 100 new CPT codes were coming into the system through a new structure called the Molecular Pathology Advisory Group that was sort of a subcommittee of the CPT panel at AMA. And they ultimately approved that for whole first wave of CPT codes, most of which were Tier 1 and were not hard to justify being covered. Next slide, please. So as we look now more carefully at that rate-setting approach that's used on the Medicare side, it's used for medical and for surgical services. But note this, that drugs aren't in that system. It was always felt that there was so much investment and research and development that went into drugs that they would let industry independently price those. But they used the rate-setting options for medical and surgical services and tried to gain much more control over that pricing. And now I think many people are wondering whether or not all of the research and development that's going into the new molecular genomics testing doesn't justify it being thought of, at least in some way, more like the drug side is. But that's yet to be sorted out. So as you look at sort of how rates get set, I mentioned earlier gap filling and crosswalking are the 2 rate-setting methods. The next step is really the methods being described for how you go through those processes, and those local Medicare administrative contractors are the ones who set the fees in this area. And then the kinds of things they look at in the fee setting is the charge for the test, as I said before, costs of resources, and these are all things that the labs are arguing with the payer about as they're going through the gap fill process to come to that sort of negotiated price that's going to be applied to the test. Next slide, please. So here's what the country looks like. Actually, this is what it looked like a few weeks ago. Whether it still looks like this today, I couldn't tell you. It has changed quite rapidly from 20 down to 10. And these various Medicare advisory contractors are companies that negotiate to be the contractor for different states and regions. So now Palmetto is over there in M. A different payer is now here in E, where in California, Nevada, and Hawaii. But it is a bit of a moving target. Next slide, please. So in 2013, as I said, the AMA had approved those CPT codes. They went over to CMS, and the first decision CMS had to make was, are these going to go on the clinical lab fee schedule, or are they going to go to the physician fee schedule. And what they decided was, interestingly, that because these tests were done by non-physicians, many of the lab directors in genetics are PhDs, they said that because they're frequently managed by these highly trained people that are not physicians, it can be on the clinical lab fee schedule. Unfortunately, they didn't at the same time decide to pay those people for the professional interpretation of these tests. So we're still sort of stuck in that quandary between them not wanting it to be a physician fee service, and the only way around that problem is to go to Congress to get approval to have the PhDs that sign out these tests approved to bill an interpretive code into the professional parts of the billing systems. But that's not in place at the current time. But needless to say, what happened is they decided to put it on the clinical lab fee schedule, and on top of that, to go through what now is the biggest gap fill process of all time. Typically, a gap fill is one or two different CPT codes that have come along that describe brand new tests. They decided to throw virtually all of genetics and genomics into this particular process, and the Medicare administrative contractors were overwhelmed by it. To get 100 rare disease tests that they really don't see much of or understand, with a continuous flow of these being presented to them as more and more tests are evaluated and assigned to Tier 1 or Tier 2. They were really quite overwhelmed. And pricing was significantly biased by the large national labs that Palmetto was responsible for, Quest and LabCorp, who have a slightly different business model than many of the academic laboratories that are heavily involved in innovation and in dealing with local patients that may have emergency situations where you need a local lab, as opposed to something that can be sent out to a reference lab. Next slide, please. All right, so here's an example of what things looked like after that first gap fill process had taken place. As I said, it goes for about 3 to 6 months, and in May or so of 2013, these were the prices that each of those Medicare advisory, excuse me, I keep saying advisory because there are carrier advisory committees, but these are the MACs, or the Medicare administrative contractors. You see 5 of them listed there, or 6 of them really listed there in this table. And one of the things I highlighted, for instance, next to molecular cytogenomics, you can see that by remarkable coincidence, Palmetto, Novitas, and First Coast came to the exact same price of $646.14. So it immediately became apparent that they had not gone through this independent gap fill process through each of the MACs, but they had actually begun to look to Palmetto, who had a contract originally, and it really began to defeat the purpose of the gap fill, which was to come to independent decisions about pricing and then be able to say across all these different MACs, we can reach an average of what the pricing ought to be, because they averaged themselves right off the start by accepting one of the MAC's payment schedules. It really screwed up the entire process and made a bit of a mess of it. Next slide, please. And as I said, the interpretation and reporting is completely different. Currently, interpretation codes exist under the Healthcare Common Procedure Coding System, or HCPCS codes, and there's a code there, but only a physician can bill that code. So the PhDs who are now acknowledged to be doing much of the work in these kinds of laboratories can't actually bill for the interpretive component of the test. Next slide, please. All right, so here's an example of, this was actually several of the MACs made a decision not to cover Fragile X testing, or testing of the FMR1 gene. Palmetto's decision says that they determined that Fragile X testing is not a Medicare-covered service, that screening in the absence of signs and symptoms of an illness or injury is not defined as a Medicare benefit. So they actually thought that Fragile X, rather than being nonspecific mental retardation, was an absence of signs and symptoms, and made a decision not to cover it at all, as opposed to even not covering it but allowing for medical necessity discussions, because certainly Fragile X is not part of any kind of screening tests at the current time. And the statutory exclusion was applied to 2 different codes, one of which was sort of something that sized the FMR allele that expands, that causes that disorder, and the second was adding a methylation component to that test. And I'll show you some more of these sorts of examples as we go along. Next slide, please. So how's all this playing out now for the community? Next slide. So as you can probably tell, I'm not terribly enthusiastic about the way this has played out thus far. They haven't followed many of the rules for coverage policy making, and some of the pricing has not followed most of the rules. So what comes from the process is that many of these MACs actually didn't go through the transparent public policy of coverage decisions. They actually did something very independently and somewhat privately, and then just posted it to their websites as if we would go looking at their websites to find out that they had made a decision about something. They didn't put them into the Medicare coverage databases, so there was no central searchable place to find out these decisions. They went around the requirements for public notice and comment. No transparency in the process. The carrier advisory committees in each of these MACs was not consulted, and they had no input. And the CPT codes were assigned without following most of the rules that are in place. They ended up with some very broad decisions. Of the 49 statutory exclusions that they made of the initial wave of tests that they looked at, 7 they said they're not going to cover them because they're asymptomatic. And that is certainly the case for something like cystic fibrosis carrier screening, which is a very high volume sort of test. It is not something that Medicare should have been paying for if their policy is not to pay for screening. But unfortunately, we do lots of diagnostics for cystic fibrosis as well. So of the 49 statutory exclusions, 7 were because they thought the folks were asymptomatic, 4 were because they were used to confirm a diagnosis made on clinical presentation, 6 were because they thought alternate tests would be available to come to the same diagnostic decision. For 2, they said that the clinical reasons would allow them to approve it on a case-by-case basis, really using medical necessity as the argument. And 6 were that the test was both diagnostic and screening, and that because there was screening, they weren't going to cover the test, even if it was a diagnostic use of the test. And 16, they said, just didn't have enough medical evidence to justify covering the test. Next slide, please. So the immediate impact on labs has been pretty significant. Many tests didn't get priced, and it was actually unclear for a very long time. Typically, it only takes 3 months to come to the decision about pricing, and labs start to get paid. However, because there was this lack of real knowledge about what genes were being tested and why the tests were being run that had been paid for, the carriers took advantage of the opportunity to both change coverage policy from what had been previously covered and to look at pricing. And all through this time, it was out to almost 6 months, accounts receivables, or the bills that you haven't been yet paid for, were starting to grow in many labs around the country. Sort of optimistically, many labs assumed that they were eventually going to get paid retroactively. That has not been the case. I know of one very large national lab that had about $1 million in bills to Medicare in 2013 and got paid $68,000 for them. Signature Genomics actually closed their business because the cytogenomic arrays were among those things that were decided to not be covered. Some argued that you're screening the genome, not realizing that the screening requirement is actually a population kind of screening, not applicable to looking at the genome and saving money by looking at the entire genome and deciding which of the variations is the important one. So labs are beginning to close around the country, and at one point LabCorp had $40 million in unpaid tests on their books in 2013. Next slide, please. So there were significant changes in reimbursement that came out of this entire process as well, because as I said at the start, much of this is around the idea of trying to lower healthcare costs, and a major concern that molecular diagnostics was rapidly rising. And I haven't seen a clean number of what that projection is. I've seen everything from it's about $1 billion industry right now and expected to be $5 billion or so in another 5 to 6 years, all the way out to $75 billion. But I assume that those differences are because sometimes they include infectious disease testing in the calculation, but it's really hard to get into the weeds. But you can see in this table that for a group of tests that you can see what those CPT codes stand for down below, the price changes have been very significant, and they've ranged from about 45% reduction in reimbursement to as high as 90% reduction for some types of tests that are being done. So it's had a significant impact on the labs, which is why many of them are in difficulty. Next slide, please. So many of the Tier 2 tests were not handled appropriately. They were, as I said earlier, they thought they were research. They said they're not going to cover them. Pre-authorization is fundamentally being required everywhere for many tests for which they made an exclusion of coverage, but allowed for that medical necessity argument to be made. However, where they said statutory exclusion, you can't have that argument, and there are many tests which we think are justified for coverage that are trapped in that statutory exclusion box at this current time. And it's clear that many of these decisions were made through website statements, and that in only 7 of the 49 tests that were where coverage decision made was the test only used in asymptomatic people. Next slide, please. So that shows you where many labs are sort of hanging by their fingertips right now because their fiscal viability has been severely impacted, because so many of these decisions about coverage and pricing were made after they had already delivered tests that were previously covered, and now they're sort of looking at very large losses that they have to deal with while they're adjusting their business operations. Next slide, please. So we've had a fair bit of collateral damage from this. Did we skip a slide? Next slide, and next one. There we go. So there's been collateral damage, as I said. They had reopened coverage policies and changed their mind about some things. They ignored the legislated requirements for coverage policy. Labs were starting to close. There are, in our training program, World in Genetics, training programs have to have a molecular diagnostic laboratory on site. So now the training programs are beginning to be jeopardized because they've lost the laboratory locally. And those emergency situations where you need local access to testing is getting compromised because those labs that close are forced to go out to reference labs. Next slide, please. So the statutory exclusion problem continues, and it's something that you can't appeal. So there's a lot of organizations dealing directly with CMS to try to see if we can't get changes made to that policy. The payers are looking to Medicare for input on pricing. State Medicaids are no longer covering and paying for medically necessary tests. There's a very incomplete picture of the medical evidence that has been used in their decisions without transparency. And this whole area of decisions has spread to other MAC jurisdictions because they didn't have the capacity across all the MACs to do these kinds of analyses of the tests appropriately. So we're ending up with sort of a de facto national coverage decision because many of them accepted a single MAC's analysis of what was appropriate for coverage and payment. Next slide, please. Let's keep moving. I think we are going to run out of time if we don't. So obviously we have a real disconnect between what the genetics community thinks is appropriate for coverage and pricing and what the payers and Medicare think is appropriate. Next slide. And sort of the classic image where there's a bunch of information on one side and a decision has to be made, but right now we're sort of in that miracle happens in the middle somewhere part where we're trying to figure out what they really want us to tell them about a test to be justified to cover it and pay for it. Next slide. And that's very much where we're stuck right now. They've raised the bar considerably on what justifies coverage of a test. We were told at a meeting at Medicare headquarters that there is no inherent utility in having a diagnosis. So the whole diagnostic odyssey that someone might go through, which can be incredibly expensive, is not a justifiable reason for a diagnosis. Knowing that the physician changed aspects of their management of the patient because they knew what the diagnosis was also determined not to have any inherent utility. Rather, that what you had to demonstrate was that knowing the diagnosis and then changing your management led to a change in outcome in the patient, and then you would be justified in covering that particular test. So that's it's made it a very complex process. Next slide, please. So I mentioned the PAMA, which is a new law that went into effect back in April. It was attached to this thing called the Sustainable Growth Rate Formula, which is the way by which they adjust pricing for the way physicians get reimbursed. But embedded in it was something about how billing codes are going to be developed and how coverage guidelines are going to be established and how prices are going to be set, with a fundamental goal being reductions of up to 75% more in the reimbursement of laboratory testing by 2022. And there's a lot of things that are going to complicate that, because it's, when you have capitated care contracts where somebody basically pays you $2 per member per month for all of their laboratory stuff for everybody in the group, it makes it very much harder to calculate pricing. And one of the things that's really going to be difficult for laboratories is that they're going to require a laboratory to report how much it got paid from every single different kind of payer that paid it, in order for Medicare or the payers to only then pay you for whatever the lowest payment you got was. So it's actually going to be a increasingly difficult problem to deal with. Next slide, please. So it's really been a fairly lethal blow to the rare disease diagnostic testing world, where utility data is very difficult to develop, and it's been lethal to innovation that many of the small academic labs are directly involved in, and to local testing. Next slide. So a coalition of organizations went before AMA, before the CMS, to begin to argue the case for why we didn't think they got this right with the process that they went through. Next slide, please. We explained that the MolDX program didn't follow the rules and all the things I've already alluded to, and that they were now denying beneficiaries access to many of the tests that were considered reasonable, necessary for therapy, for diagnosis, for whatever. Next slide, please. And we recommended a number of changes. We recommended that they limit the application of the statutory exclusion, that they be much more transparent about the entire process, pay claims that were already there until they come to final decisions, and then they begin to really follow the coverage determination process as mandated by Congress. Next slide, please. Also thought that they to restrict Medicare contractors from adopting that one payer, that Palmetto max approach to what was appropriate for coverage or not, and function independently as they were supposed to have functioned, follow the correct coding rules, and a whole series of things that are important that I don't have time to really go into, but if you get access to the slides, you can see the grim details. Next slide, please. So what could we be doing? Determining whether access to testing is being lost or not is the first challenge. So we're actively trying to identify any situations where clinicians have had patients who they thought needed to have a test done to improve their outcome, where they were denied it because of a coverage policy, or because pricing was so low that laboratories stopped delivering the test because they couldn't even recover their costs of the test. We also wanted them to understand that that the current policies were jeopardizing rare disease testing, and that it wasn't dissimilar than the Orphan Drug Act, which was designed to ensure access to rare disease drugs, development and access to rare disease drugs. We're actually going to probably need something on the diagnostic side to ensure that we can even get to the rare disease diagnostics, because it's very hard to enter into a clinical trial environment unless you know what disease you have, and even some of the features of that molecular or biochemical features of that disease. And then it's really having an impact on industry investment in all these new diagnostics. Next slide, please. So you probably got the impression that I think DNA is important, and I think they're going to have to vastly improve their approaches to making decisions about coverage and such for these new diagnostics. Next slide, and last slide, please. So we're doing a couple of things right now that we're actively engaged in. Dr. David Flannery in the ACMG office is taking the lead on getting a lot of these things set up to be able to appropriately react to the decisions that are being made and the policies that are being established. ACMG created a listserv to begin to monitor and discuss these economics issues. We hear a lot about what's happening at the state levels through this kind of a listserv. If you're interested in joining that to see what others are talking about, then there's information there of the individual at ACMG you can contact, ask to be placed on the listserv. We're developing networks of contacts in all the states, physician contacts, and we're actually working with the National Organization of Rare Diseases on this project to begin to have people in place in all the states to interact directly with the regional Medicare administrative contractors and with their state Medicaid departments. Where there are messages that we develop at the national level, we can pass them on for them to communicate at the state level, where they're going to be better received as residents of that state than we might be. And then engaging in a lot of education with people about how to navigate these processes, how to go through this negotiated pricing process with the carriers, and how to participate in this rapidly changing environment. So on that, I'll say thank you. You can hit the next slide, which I think says the same thing I just said, which is thank you. And we can pass it on to our next speaker.
Great, thank you, Mike. I'm going to pass it over to Deb, and then after that we'll take questions. So Deb, again, Debra Lochner Doyle is the Washington State Genetics Coordinator.
Thank you, and thank you, Leanne and Sylvia, also for inviting me. And Mike, thank you so much for setting the stage so wonderfully. I'm going to ask people to kind of sit back and relax, because I'm going to tell you the story of what Mike just described as it played out in Washington State. I really don't know how much I have to offer regarding webinar and issues with molecular genetics testing, other than to say we certainly have had them in Washington. Next slide. So let me just tell you a little bit about genetic services in Washington. The stars represent roughly 44 regional genetic clinics, and a definition of a regional genetic clinic for us is any facility that employs or contracts with a board-certified medical geneticist or genetic counselor. So I think we have reasonable coverage throughout the state. It is a large state with about 6.5 million people. And we also have some laboratories as well. Mark mentioned Signature Genomics is closing. Actually, they were based in Spokane, and they sold to PerkinElmer, which is basically the story of the big fish swallowing the little fish. But we also, of course, have the Seattle Children's Hospital and University of Washington, just to name a couple of other laboratories. Next slide, please. So what happened? Well, as Mike said, in 2013, the implementation of the new CPT codes, those Tier 1, 2, 3 codes, became effective. And almost immediately, I would say by February, I started receiving complaints from clinicians, pediatricians in particular, but also complaints from laboratories saying, what in the world is going on? Because things that they used to have covered were now no longer being covered. So I'm going to ask you to go forward one slide, Leanne. So here's an example, and I could have chosen from hundreds, but here's just one example of a complaint. And I'm not going to read it to you. You can read it yourself. But again, the issue is quite simply that people were accustomed to being able to order molecular genetic testing when it was medically appropriate and have it covered. And that was true for private payers in Washington, some exceptions, but it was also true for Medicaid. And Medicaid wouldn't necessarily require a pre-authorization if it was a pregnant person, because again, we have laws that require that. But for pediatric and adult, they would require a pre-authorization, but it was fairly simple to do this. And in fact, we had a system set up where a clinician could simply fax Medicaid, and they would fax back the approval, and the patient would be seen, and they would receive the services that they wanted. So again, this is a perfect example of what in the world is going on. How come we no longer are having these services covered? And this is actually out of Oregon, but of course, it's a border state, so we have patients who live in Vancouver, Washington, who drive over the bridge and are seen in Oregon. And let's go back to the earlier slide. So again, I started hearing complaints. I started saving them, and I would have forwarded them on to my contacts at Medicaid. However, our Medicaid medical director was stepping down. We knew that there was going to be a new medical director, so I was kind of holding them off, expecting that this new medical director would be named in March or April. He actually came on in May. But at any rate, I was making sure that I was going to have all this ammunition, if you will, of what's going on. We need to fix this problem. Also during that time, I learned, because I actually was talking to some of my colleagues in the Healthcare Authority, which is the state agency that our Medicaid office resides in. And Medicaid actually pays a portion of my salary. I'm actually a consultant to them. So I already have connections with our state Medicaid program. And although Mike talked a lot about Medicare, the reality, I think most of you know, is that most genetics patients aren't the elderly, although Medicare does also cover about a third of their book of business are people with disabilities. But Medicare is so influential in the policies of other payers, including Medicaid, which of course is a federal-state partnership. So again, it was helpful for me to have these colleagues in Medicaid, and I had contacted them already, and I said, you know, are you hearing these things too? What else is going on? And it was from my colleagues in Medicaid that I learned about the CMS gap fill process. And they had forwarded me several emails explaining what the process was and that they expected it to be finished by September, October of 2013, which didn't really help me in February, but I thought, well, okay, maybe there's going to be at least some, you know, light on the horizon. At the same time, we had already been working within the Western States Collaborative to try and help our state Medicaid programs within our region, because they had already been complaining about not knowing when something should be given a pre-authorization. So we had already been creating what we were called the Centralized Advisory Program for the Authorization of Genetic Services, or CAPAGS. And I'll show you a slide later that details this proposal, but suffice it to say, I was trying to not just go to Medicaid with complaints, but to say, you know, maybe there's a reasonable solution here. Maybe there's a way that we can help you in not only deciding which tests should be covered, but also cases where they should be authorized to be covered. And then, again, I continued to compile all of the complaints I was receiving, and then finally I said, you know what, let me find out. So I sent an email out to the laboratories as well as to all of those 44 genetic clinics, and I asked them, can you share with me CPT codes that you have billed that have been denied by Medicaid or anyone else, but I was particularly focused on Medicaid. And I'll show you in just a moment what that looks like. So let's go to the next slide and then the one after that. So also during that time, I received from Karen Kovac from Portland, Oregon, she's at Oregon Health Science University, this list that she had gotten her hands on that was that sort of proposed non-covered list that Mike was talking about. And I lost a few of my slides here, but that's not a problem. At any rate, I want to point out that this is a partial list. There we go. It's not everything that was on the list, but I wanted to have you see what some of this looked like that our state Medicaid was, and Oregon's Medicaid office were also looking at as putting in their non-covered services. Next slide. When I got the information back from the providers around Washington State, again, this is only a portion of the codes that were being denied, but you know, quite a few were being reported by multiple clinics. And this is actually when I was able to contact our new medical director in the Medicaid program and say, look, this is really a problem. This means that there are many Medicaid clients, residents of our state who are not receiving medically necessary services, and we've really got to address this. And once again, I had shared with him the CAPAGS proposal, and he basically said, you know, let's have a meeting. So he invited me down to Olympia, and when I got there, he had about 10 of his staff, different people from around the Medicaid office, some of whom he had already instructed to go through their billing data to really see, is this really happening? And lo and behold, their data showed the same thing. Codes that had historically been paid were now no longer being paid. What I also learned from them is that they had one of their medical directors who was assigned to kind of track the gap fill process at the federal level and to make recommendations for Washington State Medicaid program about what she felt should be the non-covered, which means you can't even question it, you can't do anything about it, even if you think it's medically necessary, versus what should require pre-authorization or should just be covered outright. And bottom line is she pretty much put non-covered on everything, but they didn't have any notes from her. She was no longer with Medicaid. She'd left the state agency, and all they knew was her recommendations, but no one knew why she had made these recommendations. Next slide. So the good news for me was that they were most interested in helping resolve the issue, and that was wonderful. I once again tried to share this sort of Medicaid, or excuse me, the CAPAGS centralized authorization process with them, which I was really trying to share with them that this will take the load off of you. Let us give this public health spin within our region, a way for you to have decisions that are vetted and that you can rely on, but ultimately you have ultimate control and the decision making is yours. Unfortunately, they didn't buy it, but next slide. The good news is that I made a lot of new friends and colleagues at Medicaid, and they absolutely did agree after we spent about 3 hours with, again, different staff pulling out different data that we looked at for, every which way we could, and basically said, okay, what we're going to do at this point in time is we're going to take those non-covereds off all of those CPT codes, and we're going to change them to pre-authorizations instead. Not a great way to go, but it was a compromise I could live with, because at least as a pre-auth required, you had the ability to say, and even the retinoblastoma case, had the ability to go back and say, this is medically necessary for these reasons, and this is how it will change this person's medical management, and then those will be covered. So it was a step in the right direction. I was pretty happy with it, although I would have preferred to have a lot more cover any time. And again, a commitment that they are going to resolve the problem. And so we have an ongoing sort of every other month we get together. Is this working? Is this not working? And really, again, trying to work collectively and collaboratively to make this in the best interest of Washington residents. Next slide. Now, obviously, some of the challenges of all of this, I think Mike couldn't have painted a better picture, but for me at the state level, it was really connecting the dots. I didn't really know everything that was happening at the federal level. I had to kind of learn about it through my Medicaid colleagues and through the College of Medical Genetics, et cetera. It would have been nice, and maybe this new listserv will be the way that we can have a more cohesive sharing of information. But even with the connections that you might have within your state, it may not have as much influence as you would like. Again, I would have loved for them to say, yeah, that KPAGS, that sounds really great. They'll visit it again if we continue to have complaints, but for the most part, they feel like they can resolve this internally, and I'm going to let them try, because that's what you do as a partner. So that's kind of the Washington State story. I think that's the end of my slides, and unfortunately it doesn't leave a whole lot of time for questions, but let's open it up for questions.
So yeah, thank you, Deb, and thank you, Mike. So if anybody has any questions, please go ahead and type them either into the chat box or into the question box, and I'll go ahead and read it out loud. But while people are doing that, I had a quick question for both Mike and Deb. So do you think people could repeat what Deb did in their state with Medicaid for statutorily excluded CPT codes despite these LCDs? So even if something's been made on a regional Medicare level, could we still go back to our state Medicaid offices and get some contacts and do something similar?
I don't see why not. I mean, at least it opens up the opportunity to have the discussion, and the worst thing that happens is they get better educated about the coverage decisions that they're going to have to make on an ongoing basis about genetics and genomics. I think it's always useful to see things at work and take them as examples of things that you ought to do.
I would agree, and I would also say that, it's been my experience working with Medicaid staff that they really want to do what's right. They have to live within the parameters of federal law, state law, as well as their budgets, but they really do want to make sure that the clients that they serve get the right services that they need.
Yeah, I agree. I think they had an untenable task in front of them.
Hold on, I think Jackie just wrote a question. She said, is there any utility in ever working with private payers, or should policy work typically be approached through CMS?
Well,
I'll take a stab at that one, just because I've been doing a lot of that within Washington State. And as I said earlier, these complaints weren't just about Medicaid, but Medicaid covers about half the residents in Washington State, so it's a big deal. But the other company is Regents, that is our Blue Shield in this state, and I have not had any success working with them. I have sent them multiple emails, multiple letters, phone calls, and I don't get any return. Nobody even contacts me back, so it's been very frustrating.
Yeah, and Medicare has a lot of influence, so we started there, and they initiated the process, and we're extending our activities to Medicaid. Because for both of those kinds of payers, it's sort of a one-size-fits-all model. Private payers are a morass because you can buy any of a number of different plans, and you can actively choose not to have genetic testing covered by buying a plan that says it's not covered. or you can get the the high-level plans that say they cover those kinds of things. So it becomes a much bigger problem to engage with the private payers because they have such a wide range of policies that they're able to offer their clients.
There's a comment from Dr. Wilden. He said, I can say that experience in Idaho with Medicaid was similar to what Mike and Deb described. Tests not paid for the first half of 2013, then not allowed to order any testing, then finally pre-auth for almost everything. The problem is those reviewing, nurses and doctors both, don't have the expertise to judge. And he asks, is there a role for educating those at the pre-auth decision level?
Well, that's where the KPAGs comes in, Bob.
Yep.
Yeah, there's definitely a role for educating them. And unfortunately, the other thing I've learned is that the turnover tends to be quite high. So, once you get somebody who's knowledgeable, then they leave, and then you're back to square one.
Yeah, and I do think there have been 2 states that have made some coverage policy changes in the last month or 2 months, with Wisconsin and Oklahoma, and basically both ended up in a position of pre-authorization as the model. Now, pre-authorization isn't free because, that's physician time spent justifying to payers why they should cover something, and takes them away from seeing patients. And there's lots of analyses of what that costs the healthcare system, but at least it's better than not being able to even engage the discussion.
And then Dr. Wilden had another question. He asked, does Medicare or CMS have any MD geneticists on staff?
Not that I'm aware of. The only place where I know where clinical geneticists are involved is in the CACs, or the carrier advisory committees, that presumably are used to help them understand coverage, to help make coverage decisions. But as I said, in this whole process, they were excluded from participation.
Does anybody else have any other questions? Feel free to type it in now. Otherwise, and Mike and Deb, do you have any other comments?
I'm already sufficiently depressed.
I know, I was pretty
it's 2 steps forward, 1 step back. I'm an optimist. I think it will get fixed, and what I'm really looking to is when we really move with Affordable Care Act to paying for performance, and if what we really have to do is keep people healthy, and we need to keep people out of hospitals, et cetera, we're going to have to start thinking about how do we make sure that genetic services is included in what is viewed as quality performance.
Yeah, and that means how do we capture the data that documents it.
Oh, and
keep your eye on the clock.
Sorry, I have one more question from Dr. Wilden. He asked, is there a role for NHGRI in straightening out this mess?
Well, I know that they have, I've had some discussions with them, and I know they've had discussions with CMS. I don't know that they have at least at the level of the staffing of NHGRI, they probably don't have people who actively deliver clinical genetic testing at the current time, and they don't bill their services because they're in a very different kind of payer environment inside the NIH and its intramural hospitals and things. So I don't know that they're really attuned to the problems and the solutions because of the world in which they live, but I know that they are trying to get engaged.
They also are a research agency, so perhaps the research that they could be considering on their research agenda would be understanding the impacts of these types of changes on the healthcare delivery system. Some of the issues that Mike and I have shared. I mean, from a research perspective, what can NIHGRI look at? They could look at how billing and reimbursement, when it does or does not occur, affects residents, affects real people, et cetera.
Yeah, I agree. I mean, this is all across HHS. Generally, if FDA approves something or clears a product for sale, then that automatically gets it covered. So there are, it's a multi-agency kind of issue. NIH does have sort of a regulatory science agreement with FDA, so there may be things that they could do jointly that would help clean up this whole coverage policy area that FDA is involved in, CMS obviously is, and NIH can drive some of the science by which these decisions are made.
And I think you answered Dr. Wilden's last question, which was, are there good research questions that might aid this? And you kind of both addressed that. Yep. So unless there are any other questions, I definitely want to thank both of you for your time today. I think this is really helpful for everybody to hear, and to hear both what the problems, but also some potential solutions to what's going on. So again, we will post this up to our website as well as to our YouTube channel, so anybody can freely access this if there are those who missed today's webinar. But again, I just want to really thank both Mike and Deb for spending some time with us today to enlighten us on this topic. Thank you both, and thank you to everybody for joining in.
You're welcome.
Okay, thank
Bye-bye.
you. Bye.